The role of occupational therapy in the rehabilitation of individuals who have experienced upper limb loss is to help individuals regain function, adapt, maintain, and gain as much independence as possible. It is within an OT's scope of practice to assist those with upper limb loss in the areas of pre-prosthetic and prosthetic training, transfers in functional mobility, wheelchair skills, community reintegration, and driving rehabilitation. In addition, they provide adaptive equipment recommendations, help in the provision of durable medical equipment, assist in the performance of ADLs and IDLs, and offer crucial psychological support throughout the patient's rehabilitation journey. When an individual experiences limb loss, whether traumatic or non-traumatic, it impacts them physically, emotionally, and psychologically. Their ability to engage independently in daily activities is often significantly disrupted. It's essential to recognize that no two amputations are the same. Each person presents with unique experiences, challenges, goals, and rehabilitation needs. Emphasizing patient-centered care ensures therapy sessions are tailored to support what matters most to that individual, ultimately enhancing their independence and quality of life. Because each case is different, it's important to approach the therapeutic process with humility and flexibility. Even as the treating clinician, you are not expected to have all the answers. Upper limb loss is a highly complex area of care, and successful rehabilitation often requires patience, adaptability, and shared problem solving between the therapist and the patient. While working with this population does present challenges, it's also incredibly rewarding. Trust in your clinical reasoning skills. You are equipped to make a significant impact in helping individuals with upper limb loss improve their quality of life. The ideal timeline for the rehabilitation of individuals who have experienced upper limb loss contains several phases: the preoperative phase, the postoperative or pre-prosthetic phase, the prosthetic fitting and training phase, and maintenance and lifelong care. The phases of rehabilitation depend on if the amputation is considered an elective or traumatic amputation. An elective amputation typically ensues when dysfunction, pain, or unsuccessful treatments lead the healthcare team and patient to decide to perform an elected amputation. A traumatic amputation, on the other hand, occurs when an injury to an extremity results in the immediate separation of the limb or will eventually result in the loss of the limb. During the preoperative phase, patients are assessed, educated, and prepared on their condition and the surgical level of operation. This stage is often associated with elective amputations as opposed to traumatic amputations. During this phase, a patient's joint range of motion, muscle strength, sensation, and potential functional outcomes will be discussed with them and their loved ones. The majority, more than 80%, of upper limb amputations in the United States are traumatic in nature, so planning a preoperative OT treatment plan is often unlikely. Because of this, OT programs for this patient population often take place primarily during the pre-prosthetic and prosthetic training phases. In this video, we are going to focus on pre-prosthetic training and prosthetic training in the outpatient setting. While occupational therapists are involved during acute and inpatient care, the outpatient setting often offers a wider scope and long-term involvement in the rehabilitation journey of a patient with upper limb loss. Let's start by breaking down pre-prosthetic training intervention ideas and treatment considerations. In the postoperative or pre-prosthetic training phase, rehabilitation focuses on residual limb pain management, shaping of the residual limb, strengthening, and flexibility. During this phase, potential prosthetic device options are discussed and rehabilitation goals are identified. Early intervention is vital during this period to ensure rehabilitative success and to provide support to the patient and their loved ones. The length of the postoperative stage depends on the extent of the patient's injury and the time it takes for all wounds to close and be free of infection. Pain management postoperatively involves collaboration among the care team and is accomplished with both pharmacological and non-pharmacological treatments. Figure of 8 wrapping or shrinkers are used to provide compression, promote wound healing, and protect and shape the residual limb. Training in activities of daily living, such as toileting, hygiene, and self-feeding, is implemented as early as possible to promote a sense of independence. Desensitization also occurs during this phase to decrease scar tissue and to prepare the residual limb for prosthetic fitting. Basic range of motion exercises are performed with a focus on body symmetry. Hand dominance retraining typically starts during this time as well. Psychological support and education should take place through every stage in a patient's rehab journey. This is where collaboration with the interdisciplinary team is imperative. Conducting a bilateral limb and core assessment of your patient is necessary in pre-prosthetic training. Assessing range of motion, strength, and endurance prepares the residual limb and surrounding joints for prosthetic fitting and function, reduces the risk of contractures, facilitates more smooth and efficient movement patterns, supports proper body mechanics, and increases independence with ADLs and IADLs. If your patient has unilateral limb loss, your assessment should not be limited to the affected side. Here are a few bilateral limb and core treatment ideas to increase strength and range of motion. Depending on the level of amputation, some of these may not apply. However, working on range of motion is a good place to start as it is a foundational step that supports the development of strength and movement. Maintaining mobility in surrounding joints also prevents the development of compensatory movement patterns and the risk of secondary complications like pain or injury. Stabilizing the core during resistive upper limb exercises can prepare the body to balance and support the weight of the prosthesis. Building muscle strength can contribute to the extended wear time of the prosthesis, and endurance training also improves tolerance for wearing and using the prosthesis in daily activities. When someone undergoes an amputation, their sensory input and motor output are disrupted. Individuals may experience impaired proprioception and phantom limb pain and sensations that drastically impact their coordination. You can help your patient with these challenges by working on perceptual motor skills during treatment sessions. With upper limb loss, the body becomes off balance as its center of mass changes. In the presence of asymmetry, working on single leg balance activities can help build core strength and lower limb strength, improve coordination through increased motor planning and sensory integration, and therefore improve proprioception. Graded motor imagery is another treatment idea. Graded motor imagery helps the patient increase their body awareness by working on left-right limb discrimination, imagined movements of the affected extremity, and mirror therapy, where the patient views the reflection of their unaffected limb moving in a mirror. This is if they have unilateral limb loss. Graded motor imagery can help reduce phantom limb pains and sensations. Finally, proprioception laser training is a fun way to help increase body awareness and improve motor control of the residual limb. You simply attach a laser pointer to the patient's residual limb and have the patient activate certain musculature to control the laser's movement and accurately hit designated targets. Self-care training is really important when it comes to pre-prosthetic training. Self-care training builds confidence and encourages your patient to be independent and adaptable. Putting the residual limb to work can help promote functional independence and prepare the residual limb for prosthetic use. So encourage your patient to use their residual limb in bimanual tasks and as much as possible. Don't forget that this is a learning experience for everyone involved, so use your resources to find adaptive strategies, assistive devices, and compensatory techniques. There are so many resources out there. Managing one's home after undergoing an upper limb amputation can be frustrating and overwhelming. Even though conducting an in-person home assessment is not always possible, as an occupational therapist, helping your patient address how they manage their home and navigate around their environment is extremely important in providing patient-centered care. Here are a few things to consider when it comes to home adaptation. Have your patient record pictures and videos of the inside and outside of the home to review together in the clinic. Also have them provide pictures and videos of their car. Are there any obstacles they are facing that are preventing them from getting around safely and confidently? For example, is there a doorknob that is difficult for your patient to open on their own? Maybe you can look into changing the doorknob with a lever door handle instead. Think about universal design. The principle of flexibility and use is the design that accommodates a wide range of individual preferences and abilities. Also think about the principle of low physical effort. You want the design to be used efficiently and comfortably and with minimum fatigue for the patient. If an individual has undergone an amputation on their dominant limb, retraining hand dominance becomes a necessary skill that requires daily practice. Establishing hand dominance takes time, and relearning hand dominance can be frustrating, especially when ADLs and work tasks that once felt routine may now feel challenging and unfamiliar. Encourage your patient to practice using their non-dominant hand daily. Start with simple tasks like signing their name and using eating utensils whenever possible. Additionally, suggest that your patient set up their home and work spaces to promote success. For example, move items, like a bedside table, to the intact side to encourage more frequent use of that hand. The psychosocial aspect of care should continue throughout every stage of your patient's rehabilitation journey. It's important when it comes to the psychosocial aspect of care to remind your patient that they don't have to navigate this journey alone. There are so many resources available to support them through this major life transition. Normalize and encourage clear and open communication about their experience. Emphasize that it is acceptable to ask for help when needed and just as okay to say no when they don't need it. Organizations like the Amputee Coalition, the Balanced Amputee, Limbs for Life, and others offer free education and support for both patients and their loved ones. Take the time to connect them with these resources, or at the very least, provide the information so they have access to support if they choose to engage with a group in the future. There are also several great resources out there for therapists to learn more and stay up to date on the latest prosthetic technologies. Organizations like Arm Dynamics, MedBridge, the Hanger Clinic, and OccupationalTherapy.com have educational libraries, online webinars, and various opportunities for continuing education on upper limb loss, prosthetics, and rehabilitation. Say your patient has now received a prosthetic device and is ready for prosthetic training. Let's discuss prosthetic training intervention ideas and treatment considerations. Prosthetic training begins once the patient receives their device, with OT focusing on integrating the prosthesis into daily routines, work, and leisure activities. Interventions also address emotional, cognitive, and social factors such as self-image and support systems. Training includes donning and doffing, device operation, wear schedule planning, residual limb care, and learning how to perform safe and effective transfers using the prosthesis. Patients also learn and practice how to control and position the prosthesis through various drills and functional tasks. Basic ADLs like eating and dressing are introduced early, progressing to more complex IADLs to support independence. The final phase, community reintegration, helps patients return to meaningful roles in daily life while continuing to address long-term care and psychosocial well-being. Early prosthetic training should start with reviewing key terminology, introducing the patient to the basic components and functions of their device, and building familiarity with device operation. Prosthetic technology is constantly changing, so use available resources and maintain open communication with the prosthetist. Don't hesitate to invite the prosthetist to join a training session with you and your patient. You are not expected to know everything. Collaboration is key to providing the best care. Once your patient is more familiar with prosthetic terminology and the various components of their device, you can teach them more specifics on how to properly don and doff supplies, including the shrinker, liner, socks, socket, and the terminal device. Another important topic to cover in prosthetic training is how to care for the device and the residual limb. You can check out our prosthetic supplies, wear, and care video for more details. Next, let's talk about wear schedule. When determining the prosthesis wear schedule for your patient, you want to start by having your patient wear their device for 30 minutes a day. After the 30 minutes, have your patient perform a skin check. If all looks well, gradually progress the wear time by 15 minutes every day. Becoming an effective prosthetic user comes with a lot of practice. Controls training teaches the patient to smoothly operate the prosthesis, including manipulating the various device components. Completing repetitive drills helps to refine motor control by using the prosthesis with objects of varying shapes, sizes, and weights in different positions. As training progresses, patients begin using the prosthesis during basic ADLs. Endurance training is essential to help patients increase wear time and tolerate extended use of the prosthesis during daily activities. During the prosthetic training phase, additional psychosocial support may be necessary. It's important to continue normalizing prosthetic-related terminology and encouraging patients to explore available resources and support groups. As patients begin using their prosthesis for more task-specific activities and encounter new challenges in their daily lives, therapists may suggest minor environmental modifications and recommend adaptive equipment or community resources. This may include guidance on driver training programs and vehicle modification services. The ultimate goal is for an individual with upper limb loss to continue to optimize function, adapt, and engage in daily activities that lead to a meaningful life. Take some time to review this case study on Jane Doe. As you're looking over this case study of 35-year-old Jane Doe, I want you to think about how you would proceed. Which pre-prosthetic training interventions that you've learned about in this video would you want to prioritize? Considering what you know about body-powered prosthetics, how can you thoughtfully plan and structure future sessions to support your patient once they do receive their device?